co-host. Oh,
there he is.
good.
There he is. There he is.
Okay.
Okay. Let's do it.
Okay, let's do it. So let me. So let's begin. So hello everyone. Good morning, good afternoon, or good evening, depending on where you are. Thank you so much for joining us today. So this is a Visonic Dental Global Webinar, a platform with mission to widespread and promote ultrasound usage in multiple clinical settings. For example, the RMSK, the pain management, and seizure emergency and critical care. We have been working with many global experts with different specialties to give lectures on this platform. So far, we have done over 330 webinars since beginning of 2020 and attracted over 100,000 physicians join us and over 1.6 million reviews or comments from our social media channels. So my name is Alex at Visonic Medical. It's my privilege today to have two experts join us today. Our old friends, Dr. Colin Riggini as webinar moderator, and our new friend, Dr. Don Buford as the webinar speaker. Dr. Buford will give us a lecture with topic ultrasound-guided regenerative medicine procedures, the top 4 joints. This webinar will have 2 sessions. The first will be Dr. Buford again. Then Dr. Colin will introduce Dr. Buford and moderate the webinar till the end. First, let me share my screen. Dr. Connie Riggini is a seasoned RMSK ultrasound diagnostician and orthopedic physical therapist operating as a physician extender in the Great Phoenix metro area in Arizona. He serves as a adjunct faculty at A.T. Still University with a demonstrated history of working in the higher education industry since 2013. Colin teaches radiology and imaging in the residence physical therapy program at A.T. Still University in Mesa, Arizona. Colin works as a consultant in RMSK ultrasound diagnostics and needle guide procedures for physicians across multiple specialties, and is a minority partner in outpatient surgery center, as well as managing partner for modern physical therapy in the Phoenix area. Colin graduated physical therapy school from A.T. Still University in Mesa, Arizona, and served his orthopedic residence at A.T. University as well. He has extensive postgraduate training, including additional board certifications in orthopedics, physical therapy, through and registered in musculoskeletal ultrasound. So thank you once again. So now it's your turn to give an introduction to Dr. Don Buford. Please go ahead.
Thanks, Alex. It's my privilege to introduce Dr. Don Buford. He's an orthopedic surgeon by trade. I've known Dr. Buford for about 7 years now, so it's I know everybody here is in for a treat. Orthopedic surgeon by trade, like I said, and he's a founder of Texas Orthobiologics and the current president of the Interventional Orthobiologics Foundation, as well as the founder of the Las Vegas RMSK Ultrasound and Orthobiologics course that's been running since 2008. So again, my privilege to introduce Dr. Don Buford, and you can take the show.
Thanks so much, Colin. I'm very appreciative to Alex and the Visonic team for supporting our course this past summer in July, and again for the invitation to be part of this webinar. And thanks so much to Colin, whose friendship over the last 7-8 years has just really expanded my knowledge, and more than that, what a great guy Colin is. Let me see, I'm bringing up my talk here. And if I share my screen, guys, will that work? How's that looking? Does that look good?
It's all good.
Looks great.
Okay, good. Okay, good. So Alex tasked me with talking about giving kind of a global overview of the most common things we do in the most common joints that we treat using MSK ultrasound guidance. And we're going to focus on the hip, on the knee, on the shoulder, and the elbow. And like most clinicians, the more we think about a particular topic, the more detailed we get. And I tried to really pull back and limit it to just the top 15 things that we'll see on a daily basis in a typical orthopedic, either general orthopedic or sports orthopedic practice, or in a typical diagnostic MSK sonographer's practice. These are my disclosures. As Colin mentioned, I am the director of the Las Vegas MSK Ultrasound and Orthobiologics course, which is in Las Vegas twice a year. We started a biologic orthopedics journal a couple years back. I'm one of the founding editors of that journal. I am the current president this year of the Interventional Orthobiologics Foundation, which is really geared towards the same topic as this webinar, merging MSK ultrasound along with evidence-based orthobiologics treatment for our orthopedic patients. And I'm a consultant with Trice Medical, which is a company that is very active in the regenerative medicine space and in the orthopedic imaging space. And so these are the crib notes, if you will. We're going to talk about these 4 joints. I've got it finely tuned to 4 points at the knee, 4 points at the hip, 3 points at the elbow, and 4 points at the shoulder. Obviously, there are many you'll get with my colleagues is, why do I need ultrasound? I've been injecting joints. I've been injecting my orthopedic patients without imaging, my entire practice. Why do I now need to go back and learn another imaging modality? And I think everyone gets the thought behind this image that you see on the screen. Anytime you can see something with your own 2 eyes, assuming you have pretty good vision or corrected vision, you're usually going to be able to accomplish your task better. Imaging of the human body is the same way. We can do very well at very many different areas in the body with palpation guided injections. It's just that I think we can be better at virtually every part of the human body using ultrasound imaging. It's the only imaging modality that gives us dynamic, real-time imaging of soft tissues in the body. And so let's go into the knee. These are the 3 main areas that we inject around the knee, most commonly the knee joint, the medial collateral ligament, and the patellar tendon. Most clinicians that use ultrasound guidance to inject the knee approach the knee in the fashion that you see here in this image on the left. This is a left knee. The transducer is aligned in what we would call the short axis across the knee, just superior to the patella. And the needle is coming in from lateral to medial. The goal here is to find the clear space, basically just superior to any prefemoral fat or anterior to the fat pad that's often in this area, just anterior to the femur. And so because this is an in-plane technique, we get a nice hyperechoic image of the needle as it comes across from lateral to medial. And our goal here is not to target a specific area. We're just targeting this hypoechoic or dark black area that represents the intra-articular space in the suprapatellar pouch. And so that makes our injection into the knee joint 100% accurate. One of the things you want to be careful of is you do not want to leave the tip of this needle just anterior to the bone. If this needle is coming down here, you may actually be into the fat pad or into synovial tissue, and that may limit the intra-articular injection that you're trying to give the patient. I should say here, there are at least 2 ways to inject every structure. The terminology that we use most often relates to the transducer alignment, whether it's short axis or long axis, referring to the tendon or ligament or joint that we're evaluating. And then we also use a second a bit of terminology to distinguish whether our needle is in plane or out of plane with the long axis of the transducer. So you'll hear me say that if you haven't already become comfortable with that terminology, you will by the end of this brief lecture. So the second knee structure is the medial collateral ligament. This is just a brief anatomical review. This is superior, this is distal. So we have the superficial MCL here. We're all familiar with the intimate connection it has with the medial meniscus at the joint. And then here we have the superficial MCL inserting distally. With the patient in the supine position, this is a relatively easy thing to image. We just have our transducer aligned in the long axis along the medial aspect of the knee directly over the ligament. In this graphic, you can see the red arrows are denoting the extent of the MCL. There are some neurovascular structures to be aware of, but usually do not come into play. We have the saphenous nerve that crosses just distal to the joint line here. And now in the ultrasound image, remember this is going to be a rotated image. So the femur is on the left here, superiors to the left, distals to the right. This is the tibia, this is the femur. We have a superficial layer and we have a deep layer. So superficial, of course, is going to be most superficial, away from the joint line. And you can see the white kind of asterisk denoting the superficial layer of the MCL. You can see disruption of the MCL in a higher grade sprain or tear, either at the femoral or tibial insertion, usually denoted by a large asymmetric hypoechoic area at the origin or insertion. And then the deeper layer is going to be more adjacent to the joint and more intimately associated with the medial meniscus. This would be kind of the medial aspect of the medial meniscus heading to stress that fact. Patellar tendon is another tendon that we commonly see clinically. It's a tendon that is involved in diagnoses like jumper's knee. Of course, it can be traumatic tears of this tendon as well, or just chronic tendinopathy. This is a relatively easy structure to image. One of the pearls that we teach a lot in our course is we like to place these tendons under a little bit of tension. And so you can see here, we have a towel rolled up and placed underneath this patient's knee because that flexes the knee a little bit and places the patellar tendon under a little bit of tension. When this tendon is under a little bit of tension, it becomes a little bit easier to see this type of hypoechoic defect that represents a partial tear at the inferior pole of the patella. And it's obviously a deep surface tear. So superficial is up here, this is deep. This would be described as in the proximal patellar tendon. And if we wanted to be even more specific, we could measure this and say it may occupy, in this one image, it may occupy about 30 to 40 or even 50% of the overall width of the patellar tendon in this long axis view. So this is a long axis view of the tendon, and here we can see this hypoechoic defect. If we were going to approach this with an orthobiologic injection, we could approach this either in plane, bringing our needle along the path shown here by the arrow in plane, or we have another way to do that. This would be the in-plane approach. We could target the inferior patellar pole and inject whatever our orthobiologic of choice is into this region to try and stimulate a healing response. This would be a short axis view. So notice here, I've turned the transducer 90 degrees. We are just inferior to the patella. And now as we image that same area, instead of having the fibers coursing across the screen this way, we have this oval or elliptical shaped patellar tendon just deep to the skin. And this now represents a short axis view of the proximal patellar tendon. Now, if we're going to use this image for imaging guidance, then we can bring our needle in from lateral, or for that matter, from medial, and you'll see it's an in-plane injection. And so this is a nice way to inject around the patellar tendon, because you'll see the needle as a hyperechoic structure in plane. It becomes very easy to visualize the needle. Here's another example here. We're right up at that inferior pole of the patella. So let's change gears a little bit. We'll move on and we'll talk about hip and pelvic injections. We'll certainly cover injecting the hip joint. Ultrasound can really change your practice if you're an orthopedic clinician, where you're used to sending out patients for hip injections to fluoroscopy, or sending them down to a procedure room where you have to use a C-arm to inject the joint. Now you have something that sits on a table or on a stand in the exam room where you can inject hip joints in the course of your normal practice, and you don't have to worry about scheduling. The patient doesn't have to come back on a different day, and it truly becomes a point of care imaging modality. So the hip joint is one of the early entry points into MSK imaging for orthopedic clinicians that haven't previously thought about one of the ways this can really change their practice flow and improve their care. The gluteus medius and minimus tendons are well visualized under ultrasound and can be targeted. The SI joint is another joint that's commonly imaged under fluoroscopy for injections, but is relatively easily approached using ultrasound. And then the piriformis muscle and tendon will be the fourth point that we talk about. So here's the hip joint under ultrasound guidance. It's a in-plane injection. So starting with the clinical picture here, the needle enters at the distal aspect of the transducer. I typically use the curved transducer, but I think I've heard Colin and other faculty teach the same approach using a linear transducer. So it's not mandatory that you have a curved transducer. With the needle coming in at the edge, the distal edge, this injection down to the joint is an in-plane injection, which gives you a nice hyperechoic view of that needle. The reason this injection works is because of hip anatomy. The hip capsule inserts on the femoral neck down about this region. And so if we get this nice image of the femoral neck and then the transition into the femoral head, we know that if we target the needle right to the tip of that gold arrow, that's going to be intra-articular. And so that gives us a nice entry point and a nice bony landmark as a target for our needle. And so just to stress that, this gold now represents the joint capsule. It inserts way down here. This black is joint fluid. Here's the needle coming down. We're just aiming for this transition from femoral neck to head. We don't really want to be way up here because that's where the articular cartilage is. We want to stay down close to this neck-head junction. And once we hit bone, which is an actual palpable endpoint, we can back the needle off a little bit and start to inject. And so here's an example. As we inject, you can see the flow. If you wanted to, you could turn on power Doppler, for example, on these imaging devices, and you can see the flow. Usually after 7 to 10 cc's, you'll see the fluid start to lift off the capsule. So the initial flow is here. You can see the fluid track superiorly here. So that's how you know you're intra-articular. Gluteus medius and minimus. Here, this starting from the bottom of the screen, the first hyperechoic line you see here is the greater trochanter. And so just superficial to that, you'll see the medius and the maximus. In this clinical image on the right side of the screen, courtesy of National Orthopedics, you'll see the transducer aligned right over the greater troch. I'm going to give you some more images here clinically. I'm going to move my vision here. There we go. So here in the transverse view, you can see the medius inserts more anteriorly on this facet. The minimus, rather, the medius is a little bit more posterior. And again, this is a transverse or short axis view. And the long axis view of these tendons, you can see in this example, this is superior, this is inferior. These hyperechoic structures in the tendon are just calcification. This is a person that has calcific tendinopathy of the gluteus tendons. But here you can see these tendons, and you can inject either in plane or out of plane, depending on your patient size and your technical preference. Okay, there we go. So now we'll move on to piriformis. Brief anatomy review. Remember, the piriformis comes off of the sacrum here and inserts onto the greater trochanter here. And remember, the sciatic nerve runs underneath the piriformis muscle in this region. So here's a little bit more review. Piriformis muscle, tendon, sciatic nerve. Very stylized representation of the sciatic nerve. And so here it is on ultrasound imaging. It becomes easier to identify if you internally and externally rotate the hip. When you do that, you can see the muscle coming from the sacrum here, inserting across. The sciatic nerve is going to be down in this region here, just below the muscle. And we can approach this muscle from a medial to lateral approach. I know some clinicians that do it in a different way, but certainly from a medial to lateral approach, you get a nice in-plane injection. And we can inject right at the piriformis muscle there. Here's a clinical example. This was initially published by Dr. Bird, who's a hip orthopedic surgeon or a hip specialist. And this was published 2019. You can see how they're using a lateral to medial approach here. And you can see how this is an in-plane injection. Here's the transducer, here's the needle in plane. And with this type, with this type of approach, you're going to see the needle come in across here, and you track that all the way down to the piriformis muscle or even into the muscle if that's what you're targeting. SI joint injections become things you can do in the actual exam room. Here's the anatomy here, the sacrum and the ilium. This is a picture that we're very comfortable with because we also harvest our bone marrow concentrate from back in this region. And so using that same type of technique, if we just slide the transducer a little bit distal, we'll get down to this point on the SI joint. And so we just look for that. This is the sacrum here. We'll play it again. And what you'll see here is we're looking for this mountain here. And if you watch on the screen, our injection target is right there. In this case, because it's a left SI joint, we're just targeting just to the right of that. Our needle path is going to come in just like this. It's from medial to lateral, as it's shown here in the graphic. The needle path is from medial to lateral. So let's move on to the shoulder. The shoulder is probably, if not the most common, one of the top two most common joints where ultrasound imaging just makes so much sense that if you're seeing any significant volume of shoulder patients in your practice, you have to have some ability to use ultrasound for targeting injections, for making diagnoses, for looking at post-operative patients. There's just so many different indications. I don't know how. The reason for that is because this is really the only approach to the glenohumeral joint using ultrasound where we can see the needle go all the way into the joint. The anterior approach is very difficult because you're injecting through the rotator interval and you can't really visualize your tendon. You can't really visualize your needle going down just above the subscap tendon into the joint. The posterior approach is very easy because you can have the patient either in this lateral decubitus position. If you wanted to and you were brave, you could have the patient sitting up and do it with them sitting in a chair or on the table, but you have to be very careful because some patients will have a vasovagal reaction. And for that reason, I prefer to do this injection with them in the lateral decubitus position so that there's no place for them to fall. The green rectangle is the transducer. The red dot is where the needle goes in. So you can see that this is an in-plane injection, which gives you a nice visualization of the needle. Here's a clinical example showing the transducer here, the needle coming in off the lateral edge of the transducer. I personally like injecting from lateral to medial, although you can certainly do this injection from medial to lateral. I just think that with the anatomy of the joint, I'm less likely to injure cartilage if my needle path is basically in line with the humeral head this way, as opposed to this way, where if I hit anything hard with a medial to lateral approach, that hard structure I'm hitting is the articular cartilage of the humeral head. And so that's the clinical image there. We can always rotate the arm to identify the joint. Here we're injecting a little bit of lidocaine superficial to the infraspinatus, but you don't have to do that. I might do that if we were going to be doing a more extended procedure like a hydrodilatation for frozen shoulder. But if we're just injecting a little bit of steroid or PRP, we might take this and go straight down into the joint. As we inject, you can see the fluid is deep to the infraspinatus. We can watch the fluid track and identify or make it easier to see the humeral head as we inflate the joint with whatever the injectate is. So this is just on a loop. Here we're placing a little bit of local anesthetic. And again, I would only typically do that if we're going to be placing a lot of volume into the joint because of a frozen shoulder, for example. Here's the needle coming down. We're targeting the labrum right here. And as soon as we pop through the infraspinatus, we can inject right here. and you can see the injection spreading. Here's another example, lateral decubitus position. Patient's comfortable, the clinician's comfortable. We spray a little bit of ethyl chloride on the skin. Before we do that, we move the transducer out of the way. And so we should move the transducer before spraying, like that. And then once we have the skin anesthetized with the ethyl chloride, we'll go in and inject. And then the image is going to be the same here. You'll see that needle come down, and our target is right here. So this is into the joint. Once we angle here, this is into the joint. Once the tip of that needle gets through the infraspinatus, this is your intra-articular triangular target. Subacromial space. This is a little bit different injection than what most orthopedic doctors are taught in training. I like having the patient positioned in this fashion because it delivers the subacromial bursa out from underneath the acromion. So when the patient goes in that position, the bursa gets delivered out from under the acromion, a bit more anterior, which gives us a better target. This is an in-plane injection. However, it's a short axis view of the supraspinatus. And so let me go through that and say that again. This is a short axis view of the supraspinatus. So starting from the bottom of the screen, this white line, this hyperechoic line, is the rotator cuff footprint or greater tuberosity. The second white line occurs right here, and that's the difference in density between the supraspinatus tendon and the deltoid muscle up above. And so our technique here with the patient in this position is we're going to leave the tip of this needle right here, right at the top of this supraspinatus tendon. Usually the long head of the biceps is seen right here. Our needle tip stops about 2 centimeters back, right at the superficial or superior border of the supraspinatus tendon, right about here. And when we inject there, if we're in the right spot, with just a little bit of injectate, you'll see the fluid track this way, and as we inject, you'll see the fluid come across here. But that's our target right there. In the clinical picture, we're just trying to demonstrate how this is an in-plane injection. Here's the transducer. The needle is injected in plane or inserted in plane. This is typically a 22 gauge needle like most of our injections. There are some areas where you can use a 25 gauge needle. You just have to be careful that you're not trading visualization for a smaller needle. 22 gauge needle seems to be a nice compromise to be able to see the needle this well using ultrasound. One of the clinical interests of mine is using bone marrow concentrate for partial thickness rotator cuff tears. So here's some imaging from a study that we completed last year. This is a long axis view of a left supraspinatus tendon that has quite a bit of partial thickness tearing. In this patient, we're bringing in the needle tip from lateral. You can see the needle is actually intratendinous. And what we're doing here is injecting 1 to 2 cc's, in this case, of bone marrow concentrate. We're injecting here, but you can see the fluid flows all the way over to here. You can see fluid flow all the way through here. And so that's how we know that this tendon has significant tearing in it. After injecting 1 to 2 cc's, the rest of this injection will end up in the subacromial space, which will be along this line here. This is subacromial space. And so what we found in our study, just to give you some clinical results, is we found that doing the single injection in the office with bone marrow concentrate gave people pain relief that was significant for 2 years. So before the procedure, people came in, they had failed physical therapy, they had failed anti-inflammatories, and they came in with an average pain score of about 6. At 3 months, that pain score was almost cut in half. At a year, the pain score on average was below 2. And at 2 years, that pain score was still below 2. So I think it's a good option for partial thickness tears. It's something we counsel our patients now. If this is the pathology they have, it's a potential treatment option. Let's move on to biceps tendon injections. Like virtually everything in the orthopedic world, there's multiple ways to inject this structure. This is just one way. I'll show you another one in a minute. But this is an injection that is based on the short axis view of the tendon. So, or if you're a MRI technician, this would be an axial view of the long head of the biceps tendon. If you're a sonographer, we're going to call this a short axis view of the tendon. When you do the injection through this approach and you inject from the lateral aspect of the transducer, this is an in-plane or in-plane injection with the needle. Short axis view of the tendon, in-plane injection. When you do that, it looks like this clinically. Needle's coming in off the lateral aspect of the transducer. When you look at the ultrasound image, here's a short axis view. If you look over here, the needle's going to come in from lateral, and our target is to leave the tip of that needle right in the bicep sheath here. So here's the needle coming down. We're going to leave the tip of the needle right next to the bicep tendon. Just like that. And as we inject, you'll see the injectate almost outline the biceps tendon here. Okay. And at the end of that injection, you should see a hypoechoic kind of halo around the biceps tendon. There's another way to do this injection. So here's another example where we just rotate the transducer 90 degrees. That gives us a long axis view of the long head of the biceps tendon. We're still going to do this in an in-plane approach. And so the needle insertion point is going to be just proximal to the transducer. Basically, this red arrow is the needle path. And now what I like about this approach, especially teaching people that aren't used to using ultrasound guidance for this injection, is they can really take whatever needle path they want. All they have to do is make sure that the needle ends up just above the long head of the biceps tendon here. So you can do that here. You can leave the needle here. You can have a more oblique approach and leave the needle tip down here. So there's a lot of margin in order to do this injection using this long axis view of the tendon and doing a in-plane approach. And so here's a patient where we're doing just that. We're spraying the ethyl chloride at our insertion site. And after we spray, we bring the transducer back. Needle goes in here. On the ultrasound image, it looks like this. When you inject, you can see how whatever you're injecting basically hydrodissects biceps pathology. The AC joint, yet another area that we can approach in multiple ways. However, because it's a very superficial joint, I prefer to approach this joint with I guess you would consider this a long axis view of the joint, because here's clavicle, here's acromion, but it is an out of plane injection for the actual joint because the joint is so superficial. Quite often, the distance that you need to go through the skin to get into the joint here is only a centimeter, maybe 1.5 centimeters max. And very often we're doing this with a 25 gauge needle. So the key to any of these out of plane injections is to get the target in the middle of the screen. Look at your depth markings on the side of the screen, and you can see, okay, here we are in the middle of the screen, and I would like to be 1 centimeter deep. And so when you do that, you now know that the needle needs to come down right in the middle of the transducer and just go down 1 centimeter. When you do that, even though it's an out of plane injection, very often you can still see the needle point. And very often you can see here, you can still see the needle in soft tissue motion. And as we inject, you can still see the fluid going into the joint, even though it's an out of plane injection. So here's a big, strong weightlifter. He's got weightlifter shoulder. He's got distal clavicle osteolysis. He's got symptomatic, he's got pain when you push on the joint. So we're going to do this injection. And because this is an out of plane injection, I'm just getting the joint centered on the screen. And then I'm going to say, okay, look, on this patient, we're only needing to go about 1.2 centimeters deep. Here's the needle coming down, do the injection, and we're done. The AC joints, one of the joints that's not easy to inject without ultrasound guidance. It's an oblique joint. The literature shows a success rate that hovers from 50 to 80% if you're just doing it by palpation. And even on the successful injections, it may not be the first stick. Using ultrasound makes this into an injection that you get the first time every time because you can see it very easily on the screen. And then finally, we'll talk about the elbow. Lateral tendinopathy or tennis elbow, medial tendinopathy, golfer's elbow, and then the ulnar collateral ligament. So one of the key points to remember when we're talking about the elbow is that the radial collateral ligament is basically the deep 50% of the structure that you'll see on the lateral side of the elbow. The common extensor tendon is going to be shaded in blue here, is the more superficial 50%. So we're looking for this ridge line, and we know that the deep portion of that's going to be the radiocollateral ligament. The superficial portion is going to be the common extensor. This is what it looks like on ultrasound. This is what it looks like when you inject. This is a long axis view, and it's an in-plane injection. And in this example, we're coming from distal to medial. It's an in-plane injection, which is why we see the needle so well. We see this hyperechoic needle. This is a good example of, let me restart the video for us. This is a good example of how when you inject, you can see this patient had more pathology than we would have expected. When we inject, we can see this radiocollateral ligament and even the common extensor origin start to lift up a little bit. So whereas we might have thought initially this was just a small tear in the extensor carpi radialis brevis, we can see with a little bit of injectate going in that this patient's elbow is actually quite a bit more damaged. It's another example. We can see this ridge line here that we get by placing the transducer directly over the lateral elbow. And now we're going to shift to the medial elbow. Let me go back, I'm sorry. Very similar imaging on the medial side. We're looking for this ridge, and when we're going to inject, it's typically a distal to proximal approach that gives us an in-plane injection. And typically when we're using something like platelet-rich plasma, we're going to make a couple passes, 2 or 3 or 4 passes with our needle just to stimulate a healing response, and then we'll inject our platelet-rich plasma, usually starting from the bone, or if there's a hypoechoic defect to target, we'll incorporate that into the procedure and into the technique as well. So I think that puts me right at about 40 minutes. I appreciate, again, the opportunity and the invitation from Alex to participate here. And Dr. Rigney is a fantastic colleague and ally, and I'm always happy to be sharing time with him in any kind of educational endeavor. So let me stop sharing my screen, and I guess we can throw it open for questions or comments. And please, anything.
So the medial elbow, specifically the ulnar collateral ligament, do you have a diagnostic criteria in the size or the type of tear that would factor into your decision-making of whether or not to perform orthobiologics or surgery?
Yeah, so there's been, and you know, again, I'm in Dallas, Texas, I'm in the United States. There has been such a tremendous rise in ulnar collateral ligament pathology amongst a younger and younger aged person that it's really shocking. And most of the data suggests this happens because we have athletes that are specializing in a single sport at a much earlier age. And especially in throwing sports, they're getting this, you know, ulnar collateral ligament damage. There have been some published papers on this question. And the nice thing about orthobiologics for this injury is about 70% of the time, if it's a partial tear, we can get people back to throwing without surgery. And so I urge all of my colleagues that are taking care of these patients that have ulnar collateral ligament injuries, anything short of a complete tear, or if it's a complete tear, especially at origin and insertion, those most likely need surgical reconstruction. But if it's a partial tear, then I think using ultrasound to place PRP once, or if need be twice, is a great clinical option. We're saving probably 6 to 7 out of 10 people that would have otherwise gone to surgery. We're saving them from a surgical procedure that takes months to sometimes a year to recover from, often not back at the same level. I think it's something that's really shown up. Most team physicians that are taking care of professional athletes that throw are clued into this data, and will give someone a chance to recover with orthobiologic injection. Again, unless it's a complete tear.
Awesome. Okay. Which types of meniscus tears, in your experience, have you seen respond better to orthobiologics?
So yeah, the meniscus, all meniscus tears obviously are not the same. Right out of the gate, we can say anyone that has a meniscal root tear, where the root of the meniscus is torn, that in my opinion is a surgical problem because it's unstable and there's no liquid that I can inject that's going to reconstruct and reattach the root of the meniscus. So that is a kind of a no-brainer. The typical degenerative meniscal tear, where somebody has maybe mid-grade arthritis also, those are perfect candidates to try an orthobiologic injection, because we're finding that, well, we already know that arthroscopic partial meniscectomy for somebody who's got an arthritic degenerative meniscal tear really may not be doing them any favors if you follow them longer than 6 months. They might have been just as well without. So my target with using orthobiologics for that patient is not to have the meniscus tear heal, it's to shorten that time interval. Somebody comes in, they've been hurting 2 or 3 months. I don't tell them the meniscus tear is going to heal. I tell them that, gosh, it's been going on a long time. I don't think surgery is the answer, but let's shorten this time interval and get you back to functioning quicker. And I think that's a perfectly legitimate way to look at using PRP for those tears. So radial tears, tears that aren't unstable. If somebody has a bucket handle tear that has their knee locked, that probably needs to be reduced and stabilized with sutures. The younger the patient is with significant meniscal tear, the more likely I am to recommend meniscal repair. Surgery for just a partial meniscectomy is exceedingly rare now in my practice. If we're going to surgery, it's usually to save it and to repair it.
Awesome. Great answer. So you mentioned you performed hydrodilatations for adhesive capsulitis. Can you describe your technique? And you described your needle approach, but maybe describe a little bit about how you do that, the volume of fluid you use, and that sort of thing.
Yeah. So for me, however a patient arrives at having the diagnosis of adhesive capsulitis, usually by the time they come to see us, it's hurting. They've lost motion, and the underlying structural pathology that really limits their recovery is a significant thickening and inflammation of the joint capsule, in my opinion, not only anterior where the ligaments are, but also posterior. So one of the things I draw in my office is the normal capsule may be, just 3 or 4 millimeters thick, and somebody with a frozen shoulder that really doesn't have motion above shoulder level, it may be 3 or 4 or 5 times thicker than that. And so we use dilatation to try and put a little bit of expansive pressure on the capsule. Part is fantastic, and that's an uncontrolled tearing of the capsule, but to the same effect. We want to stretch that capsule out and then resume motion. Dilatation in the office under ultrasound guidance usually requires 15 to 30 cc's of normal saline. I'm not putting steroid, or if I am, it's nanogram amounts of steroid into the joint to try and treat the inflammatory component. I think PRP is a better choice for that. So 6 or 7 cc's of that injection can be PRP. Depending on how you're making PRP, if you can get a larger volume of that plasma and use that as your injectate, I think that's a great way to use the anti-inflammatory characteristics of our PRP, where we're not necessarily looking for a high platelet dose, we're just looking for volume. Yeah. And so we do that in the office. I think that's a procedure where we can also use ultrasound to do a suprascapular nerve block at the same time to try and give patients some pain relief. So it becomes a kind of a multimodal approach, all of them dependent on ultrasound guidance to do something in the office that otherwise would have been done in surgery or would have been sent to the radiologist to do in a different place.
Cool. Yeah, start PT right after that?
Yeah, as soon as possible. As soon as possible. Yeah.
Cool. Okay. So the rotator cuff tears. Do you have a inclusion or exclusion criteria in determining, that would factor your decision as far as to use orthobiologics or go to surgery?
I do. And as much as possible, I try and stay evidence-based, understanding that the evidence is still being developed in some cases by us, literally people on this call. A full thickness tear, certainly a traumatic full thickness tear. So if you or Alex are fine today and you slip riding your bike tomorrow and you have a rotator cuff tear, those types of traumatic tears, I think, deserve to be repaired. I think we fix those, people get back to function. I think that's kind of a no-brainer. My father, who's in his 80s, if he has a rotator cuff tear and it's degenerative and he's had it for 6-7 years and now it's starting to hurt, but he's still got good motion, I think that's the type of patient where an orthobiologic injection can help minimize someone's pain and maintain their function without having to go back in and do a surgical rotator cuff repair in a full thickness tear. So that's the type of full thickness tear patient where I think orthobiologics makes sense. Degenerative tear, somebody who still has maintained motion and strength that they're satisfied with. Even my father, if he said, look, my problem is strength, I don't have the strength, and he's got a tear that's this big, I think the only way I can give him strength back, if he really wants that, is to try and reattach it back to the bone. There is a large patient population that have partial tears. And the party line in orthopedic surgery so far, even today, is, we'll rehab you, we may needle it, we may, do some other tricks. God forbid that includes a lot of steroid, but we could try laser, we could try shockwave. And if that doesn't work, we're going to operate on it. And we're going to complete the tear or do what's called a partial thickness repair. And that's what most shoulder surgeons will tell patients now. I think with our data on PRP and on bone marrow concentrate and some developing data even on adipose, we're going to be able to tell these people, and we do now tell these people, there is another option that has a chance to give you 1 to 2 years plus of enough pain relief and enough functional return that you may not even know that you have a partial tear anymore. I always get the question, will this heal my tendon? And I tell them that in the best data that I have to date, I can't tell them that the MRI scan is going to be better in 2 years, at least not with the current formula that I have anyway. So when I use bone marrow concentrate, put some in the tendon, some in the subacromial space, I think it's fair to tell them that the tear is not going to progress, because at the 2-year mark, our patients' MRI scans had not significantly gotten worse, but by the same token, they hadn't all healed either. So my informed consent with those patients is, if I can get you pain relief and the tear doesn't get worse, and you understand that we're not burning any bridges, and it's a cash pay procedure, if all those things line up and make sense for you, I think it's a great option. If somebody wants to have a single procedure, has the time for recovery, understands that they're going to go through some rehab with Dr. Rigney, then I think surgery is a reasonable thing. But I still think trying an orthobiologic injection before surgery makes sense. Most people are in the middle. They have tendinopathy, and those are the people where orthobiologics, I think, makes sense. Yeah,
somewhere in that curve of where they're strained to failure, and you're catching them somewhere in that range. You had a nice slide on the BMAC in the rotator cuff. Is that your preference? In the rotator cuff, bone marrow aspirate?
It is now, and it is because the first study we did was using PRP, and patients did reasonably well. We had about an 80% response rate. Response meaning patients reported 50% reduction in pain and corresponding improvement in function. Those results started to diminish, meaning patients started to have more symptoms at about a year using PRP. With BMAC, I stopped that study. We stopped collecting the 2-year data about a year ago. So we're just about to revise it with 3-year data. But at 2 years, patients were still, they started at a pain of 6. They were still at a pain level of just under 2 years later from 1 injection. And that was a statistically significant improvement. And so I tell patients, if you want just 1 injection and you say money is no object, the BMAC, I think, is giving us a longer result with better pain relief. Yeah. In the United States, there's a difference in cost that has to figure into it. And so being fully transparent, in my practice, PRP for that indication, $650, BMAC is $2,800. So people have to weigh that. And I believe me, I wish it was free. But at this point, even those numbers are below the national averages in this country for those injections.
Well said. Do you use a platelet counter in your office?
I do. I think that's really important. These orthobiologic injections are drugs. They're biologic drugs, but they're drugs. And one of the ways we have to measure PRP, one of the real markers we can follow is the platelet dosage. And the only way to get that is to run it through a hematology machine. So, and if you do that, you might as well have a registry. So that means you better have a way to store that data, because we really don't know what we don't know, which is a platitude that you hear a lot, but it's really true in orthobiologics. We don't really have a set platelet dose that I need to reach for this rotator cuff patient. So we're still kind of in that stage of more is better, with very few exceptions. There's some areas where we have a pretty good idea. I still think that getting into the 5 to 10 billion range of platelets per procedure makes sense for most of the orthopedic arena that we're dealing with on a daily basis. And so that means you've got to get your platelet count. If the average human platelet count, let's just say it's 200, you need to concentrate that platelet count about 6-7 times to get above 1,000. Let's just say 5 times minimum, 5x, to get above 1,000, which is 1 billion per cc. And then you inject 5 or 6 cc's. So the only way you can tell that is you have to do the work in the office. It takes a minute or two on most of these machines to run a sample. There's a little bit of upfront cost, but in the face of a cash pay procedure where we're trying to prove this up clinically, I think it's a research element that most of us need to do and need to use if we're doing these procedures.
Yeah. No,
and then one other
sense.
little comment. Yeah.
Go ahead.
And that's PRP. And I know there's organizations that are geared up to start collecting this data on every injection that's done in orthopedics. The Biologic Association is who I'm thinking of when I say that. And that's a multi-specialty, multi-society association. All of them orthopedic clinicians, several of them orthopedic surgery organizations. So that organization has a mandate to start collecting data and to start to rapidly, exponentially increase the registry data we have, so that we may one day be able to say, hey, you have a partial thickness tear, we need to hit 6 billion platelets. And if you do that, we know it's an 85% success rate. That's what we're trying to find out. With BMAC, with a cellular procedure, we can't really culture cells same day. So the best proxy we have at this point is just the total nucleated cell count. That doesn't always correlate with the CFU cell count from a culturing, from culturing those cells in the lab. So we're still really searching for the best way to identify and quantify, but certainly our bone, it is.
Another question here. What is your comfort level as an imaging tool, ultrasound? What is your comfort level in making a surgical decision based on the ultrasound evaluation? Probably depends on what you're looking at, huh?
It does. So if we start with the most, I kind of was trained and grew up initially as a shoulder surgeon, or probably 85-90% of my surgery coming out of fellowship was in the shoulder. It's still about 75% shoulder, 25% knee. And as a result, the rotator cuff is one of those things that's very accessible to image via ultrasound. I think ultrasound's better than MRI if you're looking at the tendon. For sure, if you're looking at the post-surgical tendon, ultrasound is the imaging modality of choice compared to MRI scan. If you're looking for tendon healing. And so the answer to your question for the rotator cuff tendon is I'm 100% comfortable in diagnosing that. The only time I would get an MRI scan before going to surgery would be if the insurance company required it, which luckily doesn't happen much, or to paint a clinical picture. What if that patient comes in and they say, gosh, my shoulder's been dysfunctional for 2 years and they don't have great motion. And you do the ultrasound, takes 2 minutes to see they've got a big full thickness tear, but now I want to see how much muscle atrophy do they have, because that may determine either the type of repair I do. I may need a graft, I may need a patch, or if they don't have supraspinatus and infraspinatus muscle, they may need a reverse shoulder replacement. And I have no business doing an arthroscopic attempt at a reconstruction. So that might be the one patient where I go ahead and get both imaging modalities, ultrasound and MRI scan. Luckily, that's not very common. There are ways to see the muscle belly and to measure atrophy on ultrasound, by the way, but it's not really validated in the same way that the MRI classifications are. So most shoulder replacement surgeons, if you said, hey, I did an ultrasound and here's the images, they wouldn't really be able to give you a muscle atrophy score. Whereas with an MRI scan, it's pretty standardized. And so that's why I would get 2 in that case. But the typical, again, if Alex falls off his bike tomorrow and comes in, I need to see if his cuff's torn. I'm going to do an ultrasound. If it's torn, that's all I need.
Yeah.
Yeah.
Well said. You hit on it with the rotator cuff and PRP versus BMAC, but how about like a joint take a knee joint or a hip joint, do you have a choice and a preference, or what's your decision-making process on which to deliver?
I give patients all of the information, which I see as my primary role, especially in something like orthobiologics, where, like you said, it's the tip of the spear. So I will discuss PRP and BMAC if I think both are appropriate. So let's just use a knee joint, for example. I think the best data with PRP for an osteoarthritic knee joint, the data is actually really good, by the way. There's over 30 level 1 published papers showing that it's better than hyaluronic acid or steroid or placebo. But that data also shows it's going to last 9 to 12 months in somebody who has mid-grade knee arthropathy or knee arthritis. And so I tell patients that, a single injection, we can probably get you 9 to 12 months down the road. Bone marrow concentrate and adipose are very different orthobiologics compared to PRP. There's just in the last year been some data on adipose, comparing it to BMC and PRP. The BMC data we have suggests that it's going to last about 2 or 3 times longer than PRP, which seems to be a recurring result when we get a chance in a good study to compare BMC to PRP. It's that the BMC seems to give a little better pain relief and seems to last a little bit longer. But I still am not comfortable saying that as a blanket statement. I think we need more data to prove that up in multiple areas. We do know, and we have studied BMC enough to know that it is a very different, there are some very different things in BMC compared to PRP. And one of the most important ones would be something called IRAP, which is that interleukin 1 receptor antagonist protein, which is a mouthful. We'll just say IRAP. And that is 10 to 20 times more concentrated in our bone marrow. And so as a result, bone marrow concentrate is 10 to 20 times with that IRAP, stronger anti-inflammatory. So here you have this very anti-inflammatory molecule, protein, that's 10 to 20 times more concentrated in the same 6 cc's. Play into it also, but I really don't have clear specific criteria. And as a result, I probably do 80% PRP, 20% BMAC. And a lot of it comes down to patient choice.
Yeah. Okay. Intraoperative placement of orthobiologics. What are the most common places you do that intraoperatively, either BMAC or PRP intraoperatively?
Well, starting from the ground up, I don't think there's enough data to use it to try and augment like an Achilles repair, for example. I think people have studied that. There hasn't really been convincing data that it's going to speed up or increase your healing for Achilles. In the knee, I think there's pretty reasonable data that it's not going to help with an ACL reconstruction. I think there's pretty good data that PRP can help improve the clinical outcome of a meniscal repair, with one huge exception. It's an isolated meniscal repair. I think there was just another paper published, I think within the last couple of weeks, showing that if you have an ACL and a meniscal repair, same patient, same day, same surgery, that adding any orthobiologic is probably of no value. And so when I have somebody who has a meniscus tear and an intact ACL, that's when I have the conversation of, hey, we may have a chance here to help you if we add PRP. And the technique for that, for me, is to add it at the meniscocapsular junction. So we're not just doing it intra-articular, we're injecting into the soft tissues around the repair site. You usually can't put all 6 cc's there, so the rest of it goes into the joint. But I think, trying to stimulate that increase in vascularity and the decrease in inflammation and the healing response needs to happen in the soft tissues as well as in the joint. So isolated meniscal repair. In the rotator cuff, the data is mixed. So for me, the clear indication to use BMAC right now is revision rotator cuff repairs. If somebody has a large enough tear, say 4 or 5 centimeters, that it falls into the very large or massive category, even if it's a primary tear. Anytime I'm thinking I have to augment the repair with a dermal graft, for example, then I will consider adding a biologic stimulus. If somebody has such a large tear that we can't repair the tendon, but we're doing a procedure called the superior capsular reconstruction, which is another graft type procedure where we're counting on biology to do a lot of work there. We're putting in, a tissue that has no vascularity at time 0. I think you can make a good argument to try and add some BMC in that situation to stimulate the healing. The best study on rotator cuff repair with a bone marrow concentrate augment comes out of Dr. Hernigaud's work in France. And the critical thing out of his work was the technique. It's not just injecting into the subacromial space. He put 2/3 of that injection into the bone. And so I think intraosseous injections of BMC makes a lot of sense in a lot of areas, not just the shoulder, because if you think about it, that's where the stem cells are natively. There may be a few floating around in the joint fluid, but most of them are intraosseous. And so part of the reason why these patients, like my dad, may have a degenerative rotator cuff tear is because the stem cells that were in the greater tuberosity aren't there. There aren't as many there anymore. And so the reparative ability of the rotator cuff tendon is not as good as it was when he was 30, 40 years younger. And so now he's getting a degenerative tear that's not going to heal. Well, if I'm going to take the time to repair that, maybe I ought to put some stem cells back in the bank into the bone so that they can go on and help in the reparative process. And so, it's limited. The data is not great everywhere, but I think there's some indications at this point, rotator cuff repair, revision rotator cuff repair, isolated meniscal tears, where you can make an argument that orthobiologics is worth the effort.
Yeah. Well, very nuanced conversation. Those aren't easy questions those aren't all direct questions that have direct answers. So I appreciate you kind of taking the time to break that all down. Dr. Buford, you do such a great job, man. Just in this space and explaining how to apply things and just as a teacher. So I, for one, personally, I appreciate, all that you do. And I think your work truly is going to benefit future generations, So, and that's
we finalized our contract back in Las Vegas for our next course in January. So I expect them there with an even bigger role in this upcoming meeting. And I know, Colin, I don't know if you have it in your clinical practice, but I know in our course you had a chance to see some of the new technology coming out of their research and development labs is amazing. The things that we're doing now with having the magnet-based imaging. I know I'm not saying it right, but being able to, some of these ways to image and even put a finer point on the tip of that needle as we inject are really going to revolutionize ultrasound guidance and MSK ultrasound in general. I think as we add that, more elastography, some of these other things that we're going to be seeing that will have a clinical impact. So I'm happy and always very excited to partner with like-minded companies, like-minded people in this space. So again, thank you both.
Okay.
Absolutely.
So thank you so much, Dr. Buford. This is a great lecture. So thank you, Dr. Rigney, for time moderating this webinar. So it's time for us to say goodbye. But I think the continued learning will keep going. So we will post this webinar video to our social media in case someone may have interest to study again. So welcome everyone to follow up always on social media channels on LinkedIn, Facebook, Twitter. Please stay tuned with us for all our future webinar schedules. So thank you all. So thank you, Dr. Buford, Dr. Rigney. So let's see you next time. Thank you. Have a great night.
Thanks everyone.
Bye-bye.
Bye-bye.
Night.
Talk to you soon.
Bye.
Yeah, you got it.
Bye-bye.
Record.